Hello everyone, my name is Efren Bancha. Today we are going to talk about bariatric surgery for ABSITE and the ABS. This entirely going to be flashcards. First, I'm going to display the question and then followed by the answer. So our first flashcard is what are the indications for bariatric surgery? So indications for bariatric surgery, there is a recent update, which we'll talk later, but ABSITE is still based on the old guideline. And per this guideline, indication for bariatric surgery has two main categories. The first is BMI greater or equal to 40, which is severe obesity, is one indication. The second indication is BMI more than or equal to 35 plus one or more serious obesity related comorbidities, that is type 2 diabetes, hypertension, obstructive sleep apnea, and the severe hyperlipidemia. There are two main categories. So the problem of this paper, this is actually very old paper from 1991, and it is not evidence-based paper. It is not based on clinical trial or anything. It is opinion-based. So there were 14 physicians involved in this, formalizing this guideline for an indication for bariatric surgery. Only two of them were surgeons. The rest were non-surgeon physicians. So given that there is a change now, which we'll talk about it. So from the same NIH consensus, what are the contraindications to bariatric surgery? Contraindications are active substance use, uncontrolled major psychiatric disorders, end-stage organ disease. This is controversial. Some people do bariatric surgery during transplant or after organ transplant. The other contraindications are inability to participate in post-operative care or medical condition which significantly impact surgical survival after bariatric surgery. So there is recent updates on indication for bariatric surgery. This is actually from 2022 American Society for Metabolic and Bariatric Surgery and International Federation for Surgery of Obesity and Metabolic Disorder. Per this guideline, there is, they came down on BMI. BMI more than or greater or equal to 35 is indication for surgery regardless of comorbidities. It used to be 40. Now BMI 30 to 34.9. In this population, we can consider surgery if metabolic disease present. And the threshold is lower for Asian population. For example, BMI 27.5 with comorbidities is indication for bariatric surgery, or bariatric surgery is recommended. This kind of makes sense given obesity is chronic metabolic disease, progressive disease, so it's better to treat earlier than waiting until later. So this is an easy question. What percentage of patients have resolution of pseudotumor cerebri after bariatric surgery? 90% resolution. This is actually the highest comorbidity improvement after bariatric surgery. Why does bariatric surgery improves type 2 diabetes before significant weight loss occurs? It's because of this hormonal enzyme shift change. So there is increased secretion of GLP-1, which is good, which increases insulin secretion by increasing beta cell function, and the patient will have improved insulin sensitivity and decreased hepatic glucose production. So now we are going to talk about very important hormones and the enzyme in bariatric population. So what is peptide YY, PYY, and its role in bariatric surgery? This hormone is secreted from distal ileum and colon from L cell, and it's usually released after meals, and it's satiety hormone. It slows gastric emitting, and its amount concentration significantly increases after Roux-en-Y gastric bypass. So what's ghrelin and its role in bariatric surgery? Ghrelin is appetite stimulating hormone produced by XA-like cells in the gastric fundus, and it increases hunger and the food intake. And its level significantly decreases after sleeve gastrectomy because we remove fundus in sleeve gastrectomy. So, what is GLP-1 and its role in bariatric surgery? It's it's incretin hormone, increased secretion of insulin after status post bariatric surgery. It's also like PYY. It's secreted by L cell in the distal ileum and colon. It increases glucose-dependent insulin secretion. Its amount significantly increased after Roux-en-Y gastric bypass because of the duodenal exclusion. Um, why does Roux-en-Y gastric bypass have stronger metabolic effect than sleeve gastrectomy? This is very important. So in sleep, there is no bypass, or there is no duodenal exclusion, or there is no rapid arrival of nutrient to the ileum. But in a patient with Roux-en-Y gastric bypass, there is rapid nutrient delivery to distal ileum, which stimulates L cell to secrete GLP-1 and the peptide YY. So the other term for the duodenal exclusion alters incretin insulin signaling. In obese patients with type 2 diabetes, how does bariatric surgery compare with intensive medical therapy for long-term glycemic control? There is a paper showed, it's called Stampede trial. I think this is abbreviation for surgical treatment and medication preventing diabetes efficiently, some kind of like that paper, something like that. So per this paper, intensive medical therapy plus bariatric surgery is superior to intensive medical therapy alone in achieving adequate glycemic control of type 2 diabetes in obese and overweight patients. So what are key components of Roux-en-Y gastric bypass anatomy? So very, very important. You guys have to look at the image here. So there are creation of small gastric pouch, usually 15 to 30 ml. And then there is Roux limb and below pancreatic limb. And then we create jejunum to jejunum connection, which is called jejunal-jejunalostomy. And then in this operation, distal stomach and part of duodenum proximal jejunum gonna be will be excluded. So what are the possible Roux limb routes in laparoscopic Roux-en-Y gastric bypass? This is very important. It's very important because we are going to talk about internal hernia. So understanding this is makes understanding internal hernia easy. So there are 4 ways: anterior to stomach, posterior to stomach, anterior to colon, posterior to colon. So there's anticolic, antigastric, anticolic, retrogastric, retrocolic, antigastric, retrocolic, retrogastric. So what does anticolic Roux-en-Y limb configurations mean in Roux-en-Y gastric bypass? So this is in the image you guys can see. So so Roux limb passes anterior to the transverse colon, which avoids mesocolic defect, which decreases the risk of transverse mesocolon hernia compared to retrocolic. What does retrocolic Roux-en-Y limb configuration mean in Roux-en-Y gastric bypass? Roux-en-Y limb passes through the transverse mesocolon. So in this case, we require to create a mesocolic defect, which increases the risk of transverse mesocolon internal hernia. So what is the difference between antigastric and retrocolic Roux limb? It's obvious. So an antigastric limb passes anterior to the stomach. Retrogastric, the limb passes posterior to the stomach. Retrogastric route increases potential of internal hernia. What are major types of internal hernias after Roux gastric bypass? There are three major categories. The first is Peterson's hernia, jejunostomy or intraostomy mesenteric defect hernia, and the transverse mesocolic defect hernia, which is occur with retrocolic approach. So you guys can see this image. So what is a Peterson hernia in Roux gastric bypass? So this is herniation between the Roux limb mesentery and the transverse mesocolon. So this hernia can occur in both anticolic and the retrocolic configuration. But like in the case of retrocolic, okay, so let me read the question first. Which internal hernia is specific to retrocolic Roux gastric bypass? So, which is transverse mesocolon defect hernia caused by passage of Roux limb through the mesocolic defect. So I used to confuse transverse mesocolon defect hernia with Peterson hernia. So they are two different things. So please make sure that you guys understand the difference. Why do internal hernias occur more commonly after significant postoperative weight loss? This kind of makes sense. One, we already create mesenteric defect, plus when the patient loses more mesenteric fat, that increases the risk of internal hernia. Which bariatric procedure is preferred for obese patients with pre-existing reflex disease? Please, this is a straightforward question you can easily answer on ABSITE. So this is laparoscopic Roux gastric bypass is preferred, and sleep my worst, Jared, because of the altered anatomy. What is typical Roux limb length for laparoscopic Roux gastric bypass? It is usually from 75 to 150. It's based on BMI of the patient. What is the key concern with internal hernia after Roux gastric bypass and how it should be managed? So this is very, very important fact to understand for ABSITE. So in a patient status post Roux gastric bypass, if the patient presents with clinical sign and symptom concerning for small bowel obstruction, you order CT scan with oral and the IV contrast, and it came negative. So that doesn't exclude small bowel obstruction or internal hernia. So if high suspicion is required to diagnose internal hernia. So if the patient has direct forward sign and symptom of small bowel obstruction, the patient needs to go to operating room for immediate laparoscopic exploration, even if the CT scan is negative. Marginal ulcer after Roux gastric bypass, presentation and treatment. So the presentation of marginal ulcer is like any ulcer. The patient is going to have epigastric pain, the most common sign. Then the patient has nausea, vomiting, dysphagia, GI bleeding, can be melanoma, hematemesis, in a chronic setting, the patient going to have anemia. The risk factor for marginal ulcer after Roux-en-Y gastric bypass are smoking, NSAID, and the patient actually need H. pylori eradication prior to doing Roux-en-Y gastric bypass. And steroid use and a larger pouch also increases the risk of having a marginal ulcer. It often occurs weeks and months after surgery, and the mode of diagnosis is EGD. And the treatment is usually medical and high-dose PPI, and treating, eliminating risk factors. And in case of complication like bleeding, perforation, stricture, the patient might need endoscopic or surgical revision. So next flashcard is anastomotic structure.